I just started off with a happy here. All there. That was it.
Okay, I think we can start.
Yeah.
Hello, welcome to everyone. Happy New Year, and hope we will have a better 2021. We'll have more live conferences than 2020. So the 2021 is kind of special for diabetes, and that's why I chose this topic, and particularly for insulin, because it is the 100th anniversary of the discovery of insulin. So what I'm going to do is kind of go over some of the important developments, talk a bit about insulin analogs, the limitations of current therapies, and some new approaches to resolve some of the current problems associated with insulin therapy. So as I said, 1921 was when insulin was discovered at the University of Toronto. It's not on.
I'm trying to get it on. Just go ahead and keep talking.
So yeah, 1921 was the year of the discovery of insulin. For those of you who are at home, we just had some problem with the audiovisual here, so that's why we had to go back and redo some things. So this was a very nice article that was there in Lancet last year, and this talked about October 31st, 1920, as when an idea was born. And it was when Banting, who was a practicing orthopedic surgeon in London, he thought about isolating the internal secretion of the pancreas. And then he went and met John MacLeod, who was a very well-known scientist at the University of Toronto. And they developed a plan. And by August of 1921, Banting and his student Charles Best prepared an effective extract from a canine pancreas. In 1922, January, James Collip isolated insulin that was sufficiently pure for human use. And on October 25th, 1923, Banting and MacLeod received the Nobel Prize in Physiology and Medicine for the discovery of insulin. So it's one of these. It's one of the shortest periods between a discovery and being awarded a Nobel Prize. So, I mean, they wrote this in the middle of this pandemic of COVID-19 and all the race to develop vaccines and things like that. And so 100 years ago, you know, the development, I mean, the discovery of insulin, you know, when the thought of it, when he was sitting alone and thinking about it, came about. And what was interesting about this idea that he had was that this came from, and I'll show you a little article that was written as to how this idea of ligating the pancreatic duct came. And actually it was the wrong idea, but it worked for a different reason. You know? So this was a nice article again last year talking about when it was almost to be 100 years, and to say that the discovery of insulin was just not by these two people, that there was a lot of things that were going on that, you know, helped this thing to happen. And in this context, the role of the pathologists and laboratory physicians was very critical. So there were pathologists who had studied the pancreas in patients who had died of diabetes. Then they had studied pancreas in people who had pancreatitis. They really didn't understand a whole lot of it at that time, but they knew from some of the animal experiments that if you take the pancreas out, that they would develop diabetes. So they all suspected that it had something to do with glucose metabolism, but they didn't know exactly, what was happening. So these are some of the famous pathologists and actually, who contributed to it in terms of studying the pathology of the pancreas and particularly defining the pancreatic islets, in the 50 years or so preceding the discovery of insulin. And so these are, Opie, then Wischelbaum, and then this is one of the patients that was described by Elliot Jocelyn and John Wright, who had, showing a degeneration of the pancreatic islet in someone who had diabetes at age 50 and survived for 2.5 years after that. So, there was still some preservation of some of the islet cells in that. Now, these are 3 interesting papers which also were published, before the discovery of insulin. So one of them is actually by, Collip, who was the one who purified insulin after the initial experiments. And the thing that here, what you note is that by 1916, people were really getting skeptical about the idea that that islets had anything to do with diabetes, because the peculiar islets of Langerhans, which are situated in the pancreas, have received various interpretations. That some close relationship between the pancreas and carbohydrate metabolism exists has long been suspected, but the complete failure in all attempts of organ therapy in diabetes mellitus did much to discredit this theory. So they were kind of getting to the idea that this is not where glucose metabolism is regulated. So this is the paper in 1920, which Banting was referring to when he recollected about it. And this was related to the relationship of islets of Langerhans to diabetes, with special reference to cases of pancreatic lithiasis. So what he had found was that in patients with pancreatic stones, and they had, destruction of the exocrine pancreas, there was still these islets that was, not affected. So that led Banting to think of the idea of ligating the pancreatic duct, and he thought that by doing so he would destroy the exocrine pancreas, and then he would get what was left would be all islets, and he could take it and find out what it does. So, but that's not how it works. In fact, by ligating the pancreatic duct, they actually created a bit more of a problem. There was digestion of the endogenous activity of these enzymes, and later on they found that it was actually better to not ligate the pancreatic duct when they did the islet isolation. Not islet isolation, but preparing the pancreatic extracts. And this was MacLeod's book, and MacLeod was one of the leading physician scientists at that time. He was professor of physiology, and his textbook of physiology and biochemistry in modern medicine was kind of the standard book for several decades before the discovery of insulin. So this one is one of the exhibits that is there in Toronto, insulin's Toronto's gift to the world. This is an exhibit that is there in Toronto, and these are the 4 people who were directly involved in the discovery of insulin. One is, of course, Frederick Banting, born in 1891, and he was an army physician. And he did he was graduated during World War I. So he did this article about the pancreatic duct obstruction and vascular atrophy. So that's how he thought about it, and then he did this work. But he also subsequently had PTSD and other things when he had depression. Eventually, in 1939, when World War II broke out, he actually joined the armed services and actually died in a fatal plane crash in 1941. So MacLeod was, of course, well known. He was originally from Scotland, and he was in Canada. He, became a fellow of the Royal Society, and his contributions was in actually refining these ideas and helping them develop how to do this. This is the actual Nobel citation that was given to them, which is all there at the museum that is there of the discovery of insulin at the University of Toronto. Charles Best, he was born in 1899 in Maine in USA, and the family came from Nova Scotia. He went to the University of Toronto after a brief stint in World War I. Then he graduated with honors in physiology and biochemistry. And then, of course, we know that he, as a medical student, he worked with Banting. Later, he became the chairman of the Department of Physiology in 1929. And subsequently, he was involved with Connaught Laboratories, which were involved in the actual manufacture of insulin. They, along with Eli Lilly, were the ones who initially developed the process of manufacturing it at a large scale. So he stayed at the University of Toronto for a very long time. And just on a personal note, my father actually worked with Best. He worked at the Banting Institute in Toronto and in the Department of Physiology and Biochemistry. So he was not his direct mentor, but he was the chairman at that time, way back in 1954, 55. Collip also, he was very talented, and he, in fact, the thing was, there are books written about the discovery of insulin, all the issues related to why, Best and Collip didn't get any Nobel Prizes, whereas only Banting and MacLeod got it. Although, Banting shared it with Best and MacLeod shared it with Collip. Collip was the one who actually purified the extract to get insulin, because neither Banting nor Best had the expertise to do it. He was someone who knew how to do this. He, in fact, was one of the giants in endocrinology. He was, from Edmonton, and then he has done a lot of other things in the field of endocrinology. And Collip, if he had not been able to purify it, in fact, the first few experiments didn't work because it was not, they didn't have enough insulin. There was a very interesting article, I think it was a couple of years ago, again, talking about the discovery of insulin. And one of the things was, the thing that discovered insulin was the insulin receptor. So these were people who have a bias towards insulin receptor who talked about it. And the fact that the extract that Banting and Best prepared did not have a lot of insulin. The only reason it worked was because the insulin receptor could find it. So if you take an extract and you put it in there and you have a receptor, the receptor will find it, and you have the action of insulin. So that's how it worked, because they had to give large volumes of this extract for the blood sugar to come down. And that was because the concentration of insulin in their extract was very low. In fact, For a long time, people had to inject 7 or 8 ml each time they took a shot because it was not a purified insulin. So this is just about 2 days ago, or 3 days ago, 2 days ago. This is the January 4th issue of the Journal of Clinical Investigation, and it has, obviously being 2021, it has this article on the discovery of insulin, because it's the 100th year. And again, they describe, of course, from the definition of diabetes all the way back to the Indian textbook, Madhumeha and Ayurvedic textbook, which described, or 1550 BC, so that's 3,000 plus years ago. And then the identification of the Langerhans islets, pancreatic islets by Langerhans. Then OP links diabetes to islet damage, as I pointed out there. Then they, Minkowski and Mehring, they induced diabetes by depancreatizing dogs, and subsequently here, they tried to Zulzer, was able to reduce glucosuria in a patient, but fails to develop, and they couldn't reproduce that. Then there was the pancreatic extracts by ductal ligation and ethanol extraction that didn't work very well. There was another attempt to salt extract of the pancreas, which also didn't work very well. So there were many other people who were trying to do the same thing. And of course, in addition to the Nobel Prize for Banting and Best, Sanger got a Nobel Prize in 1958 for insulin structure, Pilati for hormone secretion, and of course Yalo for the insulin beta immunoassay. So through the years, there has been a lot with insulin. So what do we have here? Now, this tells us actually how things have changed from in the last 100 years. So this young girl in A is the first, is the young girl with type 1 diabetes, where it was going to be a death sentence. The B is the letter or the note that Banting had noted, which I just told you as to what he thought about ligating the pancreatic duct. Then you have the picture of the University of Toronto Medical Building where they did their work. And then this is the laboratory where they did the actual extraction. And E is actually the calorimeter, and you can see how big it was in those days to measure glucose in the urine and blood. And this is their dog on the roof of their medical building in 1921. And then you have Leonard Thomas is the one, is a 14-year-old patient with type 1 diabetes, was the first to receive injection of pancreatic extract, but it didn't work. On January 23rd, he received a more purified extract, and this extract was developed by James Collip. So in a way, if Collip hadn't been able to purify it, they may never have found this. So that's one of the major contributions of Collip. So after that, of course, there was a lot of things going on, try to do some clinical trials. And of course, as you know, there was this worldwide thing that they found the cure for diabetes. And 100 years later, we are still trying to find a cure for diabetes. So they thought they had cured it, but it hasn't, There were insulin supply challenges during 1922. So there was this, so a series of different labs that tried to isolate it and, make it more successful. So this one is just, again, from the Rare Books Library at the University of Toronto, where all of these have been documented. So it's an interesting and very well-written article in JCI from this month. So, of course, there was also intrigue, the struggle over the credit for the discovery of insulin. It was one of the ugliest examples of tensions and rivalry inherent in the growth of large-scale science. So that is also documented in many books. There are even short films and everything that have been made. But this has been. So from the time that they discovered insulin to now, we have a lot of things that have gone on. So we know that the first use of insulin in 1922. Then we came up with the NPH insulin in 1950. Then you had the lente insulin, biosynthetic human insulin, rapid-acting insulin analogs, long-acting insulin analogs. Then you have the inhaled insulin, which later was withdrawn. Then another inhaled insulin was introduced. Then you have biosimilar insulins. And then, of course, we are in the era where we have, faster-acting insulin, aspart, and then pegylated insulin, which actually didn't eventually come up to the market, and then going on to the biochaperone, Lispro, and of course now smart insulin. So this was an article in 2015. So some of these have actually come into fruition, but some others have not. So I'll just go over some of the things that are important. So this is where we started with the identification. But these were all animal source preparations, and they maintained their full biological potency when they were injected in humans. So one of the interesting things here is that there were 3 companies that actually started making insulin when it was discovered. Lilly, Novo, and Herbst. As you know, Herbst eventually is what is Sanofi now. So Herbst, so you see the mergers and buyouts and things like that. So at this point, 100 years later, we have 3 companies that make insulin: Lilly, Novo, and Sanofi. So really, after 100 years, we don't have that many more people who make it. But there was a relatively low purity of these pancreatic extracts. They focused on crystallization of the active principle. They led to crystalline insulin, which is what the human regular insulin was. And of course, a lot of the time, what was being used was either beef or porcine insulin from pancreatic extracts. Then they developed this thing, which is the zinc insulin complex with a prolonged action. So that's where we had the lente insulins that came about. So that helped decrease the number of shots that the patients had to take. So they went from taking it very often to taking it twice a day or once a day. They developed ultra lente. So it changed over time. So what happened subsequently was the ability to study these things, to understand the structure of the insulin, and from there to try and purify it in a better manner. So we also had the observation that animal insulins could cause immune reactions. So they could develop antibodies against it, and the effectiveness may be low, or they would have local reactions due to injecting a foreign protein. So that was why there was an effort to make a human insulin. And of course, that was there were 2 things that were done. The recombinant DNA technology is what allowed us to develop human insulins by biosynthesis and increased chemical diversity. So which is what gives us the ability to add things take away amino acids, add fatty acids. So all the analog insulins came up later because we were able to modify the structure of insulin. So over the last 50 years or so is when we have been able to develop more and more insulins. So currently we have, the short-acting insulins, which includes, regular insulin, and then which is what we call the short-acting. Then you have 3 of the commonly available rapid-acting insulins. They are for postprandial blood sugar, and they have lower risk of post-exercise hypoglycemia with the rapid-actings. Then you have the premixed insulins. So they're a combination of the intermediate and short-acting insulins. So they decrease the number of shots that you need to take, and they have a biphasic effect. And then we have basal insulin, which include the intermediate acting, which is the NPH insulin, and then the long acting, which is insulin glargine, insulin dedimer, and insulin diclonic. So these are the currently available spectrum of insulins that we have. Of course, I haven't included in this slide the inhaled insulin, the Afrezza, which is a short-acting insulin. Even longer-acting insulins are currently in clinical trials where you can give the shots once a week. So this is how basically the duration of action, the onset and duration of action are altered. So the longest action that we have is degludec or placebo. Then you have insulin glargine 300 and 100. Then insulin dedimer, and an NPH insulin. This is human regular insulin, insulin lispro, and faster-acting insulin aspart. So when you look at that, that is the spectrum. This is the slowest and the longest acting insulin, and this is the shortest and the fastest acting insulin. And these changes that are there is either by making them into multihexamers, which is what degludec is. With insulin glargine, it is concentrated hexamer aggregates. The only difference here is that this has more concentration of insulin, so that there are more hexamers that are together. Insulin dedimer is the addition of myristic acid to the hexamers. Then you have NPH insulin, which has protamine added to it. So it's a neutral protamine adjudant. This is the classic regular insulin. And insulin lispro and insulin aspart have amino acid changes, which prevents them from making the hexamers and multimers, or at least disaggregates very quickly. So it is quickly has a shorter absorption. And faster-acting insulin aspart, there are a couple of changes that are made to add stability and to also make them dissociate very quickly when you inject it. So this is the spectrum that we have. So this is the overall kinetics that we have of the different insulins. The short-acting insulin, the onset of action is about 30 minutes. Peak action time 1.5 to 3.5 hours, and then the duration of action is 7 to 8 hours. Then you have the rapid-acting insulins, insulin lispro, aspart, and glulisine. They're somewhat similar, 10 to 20 minutes, 10 to 20 minutes, 1 to 3 hours for peak action, and then the duration of action between 2 to 5 to 6 hours. So that's what we have in this. And then you have the intermediate acting insulin, this is NPH, and then we have the long acting insulin. The NPH insulin has an onset of action of 1.5 to 4 hours, peak action at 2.8 to 13 hours, and up to 24 hours. So one of the things that is still a problem in terms of the duration of action and onset of action is that there is significant person-to-person variability in these insulins, in the sense that each person, some people the insulin will last much longer or much shorter, act quicker. Also, in the same individual, there is significant variation. So that's one of the reasons why when we look at patients' blood sugars and we see that there is, it's either too high or too low on one day, and you're giving the same dose and next day it's different. Some of it is related to the kinetics of the insulin, might be different on different days. So the longest action insulin that we currently have is Tresiba or Degludec, onset about half hour to 1.5 hours. And it can last up to 48 hours. So the premixed insulins have different concentrations of NPH or protamine. So this is protamine, Lispro, and Lispro in different concentrations. And this is protamine, aspart, and aspart in different concentrations. So the basic principle here is to try to reduce the number of injections that patients have to get. So this is simply, I didn't want to go through all the studies that have been done with these different insulins to see the duration of action. This is one of the latest ones. This is about Tresiba, and this is from the DEVOTE study. This was a review of DEVOTE study, but it gives you all these different other studies that have been done. So, but what it shows you here is that, when you use a drug like insulin Degludec, that the main effect, the A1C differences are not too, this is the comparator insulin is usually glargine or detamere. In some of these others, there is no comparator. So what you have here is that there is a larger reduction in the fasting blood glucose, and also the hypoglycemia event rates and the nocturnal hypoglycemia event rates are lower with Tresiba, or Degludec. But there are lots of issues in terms of study design as to whether that would make it that this should be the drug that has to be used. But certainly the data shows that you have fewer effects, fewer hypoglycemic events with these. So this is to show the pharmacokinetics of regular insulin, which is this one, and the analog insulin. So you can clearly see that there is certainly a higher peak and a shorter duration of action of the analog insulins compared to the regular insulin. So the faster-acting insulin aspart, it's a newer formulation, and what it is there is a addition of niacinamide as a absorption modifier, and L-arginine is added to make it stable. And so it is, has been used in both type 1 and type 2 diabetics. It does, as in other studies, similar A1C reduction, but superior postprandial glucose reduction with no increase in hypoglycemia. So, and also it can be given up to 20 minutes after the start of a meal. That's the advantage of using the faster-acting insulin aspart. So in individuals in whom giving the insulin, the timing of the insulin may be a problem, this is something that may be quite helpful. So this is the thing that is there. So this is the normal response. So it's very. So none of the insulins that we have actually matches the normal insulin response, and I'll come to that a bit later. So that's one of the problems that we have, and even with the rapid-acting insulins, we are still peaking significantly later and lasting much longer, which is one of the reasons why we are not able to give adequate amount of insulin, because if you give adequate amount to reach the peak at the time that we want as is normal, it will last too long, and that can cause significant hypoglycemia. So the aim is to mimic physiologic insulin profile. Even for pump therapy, when you give the bolus, if it is not going to match normal, it is not going to be as effective. So there are some issues related to the insulin analogs. in terms of complications. And these are the pros and cons of using the insulin analogs. The main thing, the rapid-acting insulins, they have a rapid onset of action. Postprandial blood sugars are better. Short action profile. Risk of diurnal hypoglycemia is better. You don't have to eat in between to avoid hypoglycemia. And avoid that way you can avoid weight gain. Risk of nocturnal hypoglycemia is lowered. Flexibility in terms of things. But one of the downsides is the cost. It's much more expensive than regular insulin. And of course, experience-wise, it depends. I think all the younger faculty and others would be much more comfortable using the analog insulins than regular insulin. And then availability, sure. I mean, you can get regular insulin even without a prescription, so you can get it easier. Concentration forms, they're present in both of them. Then even with the long-acting insulins, the duration of action, the profile in terms of it being flat, the variability, interperson and intraperson variability, risk of hypoglycemia, need for snacks, nocturnal hypoglycemia, all of those favor insulin analogs, but the problem is, again, the same in terms of cost, availability, and concentrated forms. So one of the things that we have is that back in 1922 and 1924, there was all this thing about who can get the insulin. It's expensive. It's we can't get it. And in 2021, we still have to worry about the cost of these analog insulins, because we see this quite regularly, that our patients come to the hospital because they couldn't afford insulins. So this is some of the newer ones. Some of them have come into fruition, some of them have not. That are so there is a recombinant insulin with EDTA. It's loosely packed insulin multimers with rapid dissociation into monomers. Then you have insulin with hyaluronidase. So what it does is it increases the subcutaneous spreading and accelerates the pharmacokinetics. We talked about the FIASP, and this one is the newer one, the ultra-rapid acting insulin that was developed by Lilly. I think one of our fellows or Dr. Folsom did a journal club on this particular insulin. It is insulin lispro with a biochaperone. So it has enhanced insulin diffusion. Then you have different ways of delivering it. One is to a patch that actually mild heat is applied at the site of insulin injection that increases the rapidity with which it can be absorbed. There is the intradermal delivery of insulin, which is also much more rapidly involved. Then you have inhaled insulin, which is a technosphere, which is what Afrezza is. It increases the surface area, but bioavailability and high doses are needed. So the thing is, in the past with the Pfizer inhaled insulin, Exubra, the device was very big. It was more difficult to use. It was all in milligrams, so it was difficult to use. I think Afrezza is much more friendly in that way because it is in units, but it still has incremental doses, which is what makes it a difficult insulin to use. There is an oral insulin spray in development and also a jet delivery. And then, of course, I'll talk briefly about this injectable nanotechnology that is currently being developed, which have glucose-dependent insulin release. So that will help do better. So the question is, we have all these insulins. Our goal is to give insulin in a manner that the body normally makes insulin. So how does it make insulin? So what is the pattern of endogenous insulin secretion over 24 hours? So this is a very nice study that was published almost 30 years ago by Polonsky and others, and it looked at a 24-hour period. They had 3 mixed meals, and they were 14 normal individuals and 14 obese individuals. And insulin secretion rate was calculated by plasma C-peptide levels and individual kinetic parameters. So what they found here was the insulin secretion rates were consistently elevated in obese subjects under basal conditions. So this was 11.6 versus 5.4 nanomoles per hour. So that's insulin resistance. And in the 4 hours after breakfast, it was much higher, lunch and dinner. So basically, they have much higher levels. And again, the thing is that, if you want to mimic normal insulin secretion, obesity becomes one of the other factors that we have to keep in mind and try to see how we adjust to that. So in the normal person, basal insulin secretion represents about 50% of the total 24-hour insulin production. So that's one of the things that we do. We teach our people that 50% basal and 50% bolus insulin. So that's this study shows. Whether it's an obese or lean individual, the 50% of the total insulin secretion per day is as a basal insulin, and then you have insulin secretion in between meals. So, and the insulin secretion will return to baseline between meals, and equal quantities are secreted in the 4 hours after breakfast, lunch, and supper. Even though, see that they had, the breakfast was much smaller than their lunch and supper. So one of the things is in the obese subjects, it doesn't return to baseline. So they end up postprandially having higher insulin levels than lean individuals. So whenever we give, especially when we give long-acting insulins as an injection, this is a bit of a problem. With a pump, you may be able to vary this throughout the day, but it's also not easy to reproduce. So, that is something that cannot be easily manipulated by exogenous insulin therapy. So if you look at the 24-hour insulin secretory pattern, there's also what we call longer-term pulses. So there were about 11 pulses of insulin that were produced in each 24-hour period. So it's not like it is secreted in a flat manner, that there are pulses of insulin. And it was pulsatile without a meal also. So 3.9 pulses occurring in the period between overnight sampling. So overnight when you're sleeping, there are these 3 times, then it goes up and down. So again, most of these are kind of substrate dependent or dependent on the glucose levels, so that there are fluctuations in the glucose, and that's what leads to the fluctuations in the insulin, or at least that's our hypothesis. So, in obese subjects who are non-diabetic, these are very similar, and the levels are higher, but they will have, they will have the same pulses. And in both groups, more than 80% of the pulses were concomitant with the pulse glucose concentration post-meal. So this is one of the things that shows you what happens, through the day. And you can see these are insulin levels here that you can see. These are different timings of the day. And that's why when you look at exogenous insulin, you're not getting it in terms of the timing, which is the physiologic plasma insulin profile. What you get here and what is physiological is very different. So that's a problem that even if you use a pump, is not that easy to fix. And part of it is because of the subcutaneous route by which you administer insulin. And this is to show the difference between the obese and the normal and the diabetic subjects. Of course, in the diabetic subjects, the plasma glucose is higher and the insulin responses are much lower than in the normal individuals. So this is the C-peptide and the insulin levels. So this change in the insulin secretion due to a change in both beta cell mass and beta cell function in type 1 diabetes, especially in twin studies, we have known that beta cell dysfunction occurs much before a loss of beta cell mass. In fact, if we usually recognize type 1 diabetes at this phase when they become diabetic, at which time there is certainly a significant amount of loss of beta cell mass and advanced loss of beta cell function. But even earlier in twin studies, what you find is that there is a decrease in beta cell function that you see in type 1. In type 2 diabetes, there is an initial increase because insulin resistance is part of the story that you have increase in beta cell function. There's an increase in beta cell mass, and then eventually in the pre-diabetes phase, and then of course the beta cell mass and function do decline by the time they develop overt diabetes. So one of the hypotheses is that insulin secretion and insulin sensitivity are related, that insulin secretory defect can itself cause insulin resistance, so that the issue of which came first, was it insulin resistance or insulin secretory defect. So one hypothesis is that if you can get perfectly normal insulin secretion, then everything will be fine. But if there is some susceptible beta cells, it can lead to a kind of a self-perpetuating, so there is a disordered insulin secretion, which in turn actually causes insulin resistance. Because one way to avoid hypoglycemia, if you make too much insulin, is to become insulin resistant. So that in turn causes problems with, beta cell function. So you have both what is termed insulin toxicity and glucotoxicity. So there are genetic and environmental factors that lead to beta cell dysfunction, which in turn causes this problem of insulin resistance. And of course, there are other phenotypes that may be where you have you develop disordered insulin secretion, then decreased hepatic glucose production, or you can start with insulin resistance and beta cell function is normal, but that in turn causes an increase in insulin secretion, decreased hepatic glucose output, and that causes insulin resistance at the level of the beta cell. So these two are interlinked. So one of the things that is of interest is the fact that insulin is secreted in a pulsatile manner, because all the insulin that we give exogenously is given as a single bolus or twice a day or once a day. So in normal subjects, if you measure insulin in the basal state and after stimulation, it's always secreted in a pulsatile manner. And pulsatile release leads to oscillations in insulin concentration, especially in the portal vein. So in the portal vein, it is much more apparent because the concentrations of insulin in the portal vein are very high. They're still, however, detectable in the systemic circulation. So in the fasting state, these insulin secretory pulses have an interval of 5 to 15 minutes, and they appear in the circulation, peripheral circulation. They're very well coordinated, and it's due to a coordinated action of beta cells. So each individual beta cells secretes in a pulsatile manner, but if you put them as an islet, it will work as a unit. And within the pancreas, all the, whatever 600,000 to 1 million islets that may be there will all produce insulin in a coordinated fashion, probably regulated both by the metabolite, which is glucose, and also by the autonomic nervous system. So one of the things that was demonstrated here in Louisville by Samuels and Stagner in 1980 was that if you take an isolated perfused pancreas, it will still release insulin in a in a pulsatile manner. So even if you take it out and you just perfuse the pancreas, and it had a periodicity of about 6 minutes. So every 6 minutes there was a pulse of insulin that was released. So if you suppress endogenous insulin production by somatostatin and infuse insulin in a pulsatile manner, it'll actually give you more hypoglycemia. It means it is more effective. And that's one of the things that people are interested in looking at. It may be a contributing factor to the development of insulin resistance and glucose intolerance, because if you take individuals who are pre-diabetic and study their insulin secretion profile, you will find a disordered insulin secretion. They're not regular pulses that we see in normal individuals. So 40% less insulin was required when insulin is infused in a pulsatile manner. So one of the things is, can we give insulin in a pulsatile manner? And that's something that needs to be explored. So initially, 25, 30 years ago, this was something that we couldn't think of because there was no way that we could deliver this. That's what we thought. However, there are newer technologies by which we can do this, so there are, some things. For example, oral hypoglycemic agents will increase insulin secretion. Like if you use the sulfonylurea, you can increase insulin secretion, but it doesn't change the pulsatility of insulin. So if you take a diabetic subject and look at their and give them glimepiride and study their insulin pulsatility, your pulse amplitude goes up. It doesn't change your pulse frequency. So it doesn't change. So one of the things is to try and see if we can do this, because it may have better effects. So this is a review that was published about a couple of years ago, looking at whether people have administered intermittent insulin therapy, and this has been done only in intervals. That means you come in and they give you IV insulin infusion for 6 hours, and their pulses of each hour, there are 3 separate hours in which it is given as a pulse, and then 1 hour in between. And this is done for like 6 weeks or 12 weeks. And the idea there is that if you keep doing it every week, that it will somehow help normalize the endogenous pattern of whatever insulin you're making or the glucose patterns. And there are studies that have shown that it will improve. That means intermittent insulin therapy improves diabetic ulcer resolution, neuropathy parameters, microalbuminuria, and reduced emergency visits. And of course, there are explanations as to why intermittent insulin therapy or pulsatile insulin therapy will be more effective in terms of how any hormone pulse is more effective than continuous administration of the hormone. So currently there are some smaller devices that are being developed where you can give insulin pulse as a subcutaneous infusion. The problem with the subcutaneous is that because the absorption is not quick, you won't get the pulse that you try to deliver. It won't be as quick. But there are some technologies to try to accelerate it. And of course, in animals, you can give it, put a venous infusion and show that it can be delivered for a longer time. So this is something that in the future may be interesting. So when I looked at this and I said, well, 100 years ago, if somebody told me that you could use insulin, you would not believe it because nobody had done it, and people thought it was a stupid idea because they were not able to show that it works, But now, we do. Then we have what are called smart insulin systems. So, we know that the normal, the way we give insulin is not regulated by endogenous feedback. So that's one of the problems that we have But with modern technologies, we can do that. So you have what is called as glucose-responsive insulin technologies. And basically, there are three of these types. One of them, of course, is a mechanical GRI system. And that is the closed-loop insulin pump that we use, And then there are polymer-based systems in which insulin is encapsulated within a glucose-responsive polymeric matrix-based vesicle or gel. And then there are molecular glucose-responsive analog systems. So that involves introduction of glucose-sensitive motif to the insulin molecule or its formulation. So when the blood glucose goes, it will be bioavailable and will be active. And if the blood sugar comes down, the activity of the hormone goes down. So that's the thing that is currently being studied. So one of these is this microneedle array patch. So basically, you have this nanoparticle that is there, and it is, this is a microneedle that is introduced here, and so the glucose, when it goes in, it actually, generates the hydrogen peroxide, which in turn will have an impact on the insulin release from these. These are the microneedles that are loaded with insulin. So that'll help the disassembly of the insulin from these microneedles, and it'll go into circulation. So this is one system that has been shown in animal models to work. This is another one which uses an enzyme. This is a polymer network that again has dextran and has a chitosome layer, and this can also does the same thing. That means if when it will release insulin based on the metabolism of glucose to gluconic acid. And this is a system where it's an injectable nanogel, and this will this is a polymeric matrix, and it'll swell when the glucose levels are higher and glucose goes inside, and that'll push out more insulin. So these are three different systems that have been developed over the last several years to try and improve the way it is done. So although life-saving, insulin treatment in its early days was primitive, and by today's standards, extremely difficult to administer for people living with diabetes. Early treatment was plagued by shortages of supply and variable potency. It required large doses, typically 3 to 7 ml. It was painful. They had abscesses and frequent hypoglycemia. Of course, I didn't talk to you about the issue about blood glucose monitoring. So many of the advances have modified these insulins with both shorter and longer duration of action, with replacement of animal insulins with recombinant human insulin, and improved delivery devices and pumps that we have. So they've all had a real and tangible impact, but they still have profound limitations. We still don't know how to deliver insulin in a physiologic manner. It is administered subcutaneously. Even using pumps and things like that, we still cannot accurately give insulin in a manner that you can maintain euglycemia. So, one of the alternatives in giving pulsatile insulin therapy that maybe may further refine the things, and then of course there are cell-based insulin therapies. So I will end my talk here. I just wanted to start the year with a talk on insulin because of the 100 years of insulin discovery. So I will welcome any questions. So this is the CME event code for today. Those who want CMEs. Thank you.
Dr. Mokshagundam.
Yep.
excellent talk. Really enjoyed it. Thanks for all the history and everything that went with it and the newer advances. Just the graph that you showed, the peaks. I may have missed it, but the inhaled insulin, does it have the same peak as aspart, the ultra short acting, ultra rapid acting, or is it?
So the peak is the level is the same. It's a bit earlier, and it's about 10-15 minutes earlier than the other insulins,
So
the other rapid acting.
Within 2 to 3 minutes of inhalation?
No, it's about between 5 to 10 minutes of inhalation that it'll start going up.
So it's a little closer to the physiological peak versus the others.
Correct. But as you know, it's a more difficult insulin to administer, partly because of the dosing issues.
True, but with the one that you mentioned, the spray, the oral spray, which is under investigation, does it have the same pharmacokinetics as the inhaled, since it's salivary absorption?
Yeah, I don't know. I haven't seen the data on that. One of the advantages of the inhaled is that it gives you a larger surface area to absorb. So not only is that there's a lot of blood supply in the lung, but it also has a larger surface area. So that is an advantage of the inhaled insulin.
Versus the oral, that's under investigation.
Correct. Versus the oral. For the oral things, you'll have to use some sort of a liposomal particle that will allow it to go through it. Even here, you have to use something additionally to get it across. That's what the technosphere is. So they'll have to use some. So that's why the initial ones, when they talked about dosing, actually the amount of insulin is probably a bit higher than what units we say.
Thanks a lot.
Thank you.
A lot of questions there.
Where?
This is Tanwani.
Yeah.
I missed I think, first part of it. I was wondering, it was presented any data on the weekly insulin that is in there?
No, I didn't present the data on the weekly insulin. Yeah, it's still going into phase 3.
I see.
Yeah. So
we're still waiting.
Correct. Yeah. But I'm not a very big fan of these longer and longer acting insulins because, normal insulin secretion is much more
Shorter.
Every day is different, and there's a lot of variation. I'd rather see insulins that are. That's why a pump is better. But the longer acting insulins have advantage in terms of compliance issues. But I don't think in terms of pharmacokinetics, they're not the ideal insulin.
Okay. And other thing I was on their newer pump with the Medtronic.
Which one?
Their I think they have a 770 and then
correct. Yeah.
That has the bolus thing yet, or no? They are waiting for the next one.
Yeah, the bolus calculations have always been, there is no bolus calculator. You can program them to do a certain amount, but automatic bolus calculations are more difficult, But, after a bolus, like you can give additional insulin as the blood sugar goes up. You can set up some of those parameters.
Right. So there's nothing like
there is no fully closed loop.
Okay, we don't have.
Yeah. So even now, what we have is the partial closed loops.
Dr. Mokshagundam, can I ask a
Yeah.
question?
Yeah.
Okay,
Go ahead.
Is the long-lasting same as the slow-release one, or it's a different mechanism?
Which one? The long-lasting?
The long-lasting.
Correct. Long-lasting is the same.
Is it slow-release or
correct?
a different?
It's a slow release in the sense that basically, as I showed you, the absorption of insulin depends on whether they form into hexamers or multimers, and also whether it's bound to something else. So with the Tresiba and the glargine, they're trying to make them into aggregates when you inject, and so it is slowly absorbed.
Okay.
It has to dissociate. With the levemir, they added myristic acid, which binds to the protein both in the circulation and also in the subcutaneous tissue. So it has to dissociate. So those are the things that make it slower release. So that's
Thank
what
you very much.
makes them either short acting, rapid acting, or long acting.
Yeah, excellent talk and very comprehensive.
Thank you.
So, Dr. Mokshagundam, could you put that event code back up? It doesn't seem to be in the chat.
Okay. It's 1280.
It's 1280.
Okay. I put it in there.
Oh, there it is. Thank you.
Okay. 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 So thank you all, and we'll see you again next week.
Thank you.
Bye.